Appreciate that. So today I'm going to speak a little bit on working with cognitive challenges in psychosis. And I heard one of the people introduce themselves working for Developmental Disability Board, that kind of, or working in that area. So I'll be interested in conversation kind of moving forward. My role is really working primarily from a CBT standpoint, working in psychosis. And some of the time, cognitive limitations come in of different varieties. So I'm going to talk a little bit about what those cognitive challenges sometimes look like, or the kinds of challenges I've experienced. Talk a little bit about what is necessary from a CBT standpoint to do that therapy with regard to cognitive limitations, and then talk just a little bit about adaptations and things like that. So that's what I'm hoping to cover today. So of the categories, there's sort of big three that I'm just going to touch on. One would be intellectual disability, which is traditionally defined by a standardized IQ score of less than 70 with comparable deficits in adaptive functioning. So it's not simply an ability to kind of think and reason and process, but also having adaptive functioning deficits at a similar level. Now, a note with regard to this is that individuals with intellectual disabilities have been largely excluded from randomized control trials related to CBTP, despite the fact that there's 3 to 10% prevalence of individuals who have both intellectual disabilities and psychotic disorders. So something just to kind of attend to. It also means that there's not a whole lot of literature when I was looking at things to draw from to do this work. The second category is learning disorders or learning disabilities, and this is a difficulty in a specific area of learning, reading, so dyslexia, things like that, expressive and receptive language, attention deficits, not related specifically to overall intellectual functioning, so a particular area where there's difficulty or cognitive challenge. And then working with individuals with schizophrenia, there is plenty of literature out there indicating cognitive symptoms. So the more common ones are having to do with attention, verbal learning, working memory, and social reasoning. And so working in the space of psychosis and schizophrenia in particular, cognitive challenges is something that does come up. So I'm just going to speak to that a little bit today. The first thing I'll talk a little bit about is specifically with intellectual disabilities, and then talk more broadly about cognitive challenges. So with regard to intellectual disabilities, information gathering can sometimes take longer than usual, especially if they're expressive communication problems. And so sometimes difficult to get routine historical information, and usually family or other supports are involved and can be quite helpful here. Another factor to consider when preparing for sessions with someone with an intellectual disability is their previous experience with past services, which could impact their current expectations. Issues related to kind of choice and autonomy are fairly common. And also just another general factor, whenever possible, to try to get school IEPs, evaluations, cognitive evaluations, if those are available. Those are always quite helpful. CBT, one of the core values is informed choice and shared decision making. And so an individual coming in with intellectual disabilities or cognitive limitations of any kind, we want to explain what CBT is and is not. In some settings with intellectual disabilities, there's an expectation of a longer term involvement. And so just kind of clarifying the length of involvement, how much time is involved, kind of keeping the language rather straightforward. Weekly meetings, roughly 10 to 20 weeks, lasting 30 to 60 minutes, working on ways to figure out new ways to deal with problems, how to make problems less upsetting, things along those lines. So kind of keeping it straightforward with language. And then working with the person who's before you to kind of determine the role that significant others will play. And some of the recommendations from authors in this field suggest even developing a kind of a visual map of supporters and activities just to kind of help that process. When thinking about general suitability for psychotherapy, the recommendations are to just bear in mind whether or not the individual, what their communication abilities are, memory, attention, emotional understanding. Again, there's no single benchmark with this, so you're going to have to use clinical judgment. But quite simply thinking about, a person's ability to remain on topic, particularly for CBT, ability to reflect on experiences, retain information from previous sessions, things like that are important. Now, specifically to CBT, I don't know how many, I think most folks here are familiar with cognitive behavioral therapy, and it's really based on a premise that our thoughts really mediate a lot of what we feel and what we do. And so to be able to work within this therapy, there's some minimal requirement, I guess, to be able to separate like what's the activating event or the situation. Can I put words to the meaning of that situation and also identify the emotions and behaviors or the consequences? Or sometimes we talk about the thought, feeling, behavior triangle that I have listed on the right there. And if someone is coming in and there are concerns about intellectual disability or intellectual deficits, what do we need to be aware of to do this kind of therapy? There's other approaches we can use, but if we're thinking about cognitive behavioral therapy, there's a little bit of research on this. Individuals' ability to recognize components of CBT when there's intellectual disabilities present. And so emotion recognition, particularly happy and sad, or seeing faces with and asked to label the emotion, 96 to 58 to 96% are able to do that. When you get a little bit more subtle, recognizing the worried, someone appearing worried, 36% are able to kind of recognize that. So kind of emotion recognition is part of what we look for. Differentiating, can one differentiate what's a behavior, what's a feeling, and what's a thought, right? That's part of what we do in CBT. And so can you categorize sad? What is that? This is hard. If I have that as a, in quotes, as something that's said, is, being able to identify that as a thought and then identifying separately what a behavior is. And as you can see from the charts there, folks are able to identify behaviors at a much higher rate, certainly than thoughts, like really being able to mediate or identify thoughts. And then feeling at 52% there. Now, these are all mediated by receptive language ability. So let me just say a little bit about expressive or receptive language. For those who may not have this particular background, this is a plate from the Peabody Picture Vocabulary Test. This is a way to assess intelligence. I used to love to give this test. It kind of points out the difference. If I would ask you to describe what are in each of these plates, I'd be asking you to tap into your expressive language abilities. So what's in plate one? Looks like a mom hugging a child. What's in plate two? Somebody bending over, maybe laughing. Now, when the receptive language component of this would be, rather than asking somebody to describe, I would just give you the prompt and say, which one is sleeping? And then you would ask the person to point. In this case, we'd point to number 3 on there, which would indicate that. Or you might ask which one is laughing, and then you would point to 2. And so the ability to recognize is easier than drawing words and being able to communicate things. So this is the receptive language ability, and folks who have a better receptive language ability in this sense do better on some of these other tests, which makes sense. Now, some creative clinicians have found ways to try to figure out, like, how do we know, can people work through a typical CBT sort of protocol? So typically we'd ask something like, you walk past a group of friends and they don't say hi. And normally we would say, what do you think? What do you feel? What do you do? That would be the typical CBT approach. In this case, we would give the prompts and say, you think I'm unlikable. And then ask, do you feel happy or sad? And then ask people to identify that. So can they mediate that this thought goes with this feeling? And so then they switch the thoughts, even in the same scenario, and see if the person's able to understand that their feelings connect with that thought when it switches. And then in the final example I have there is just switching it a little bit. You walk into the room and you feel happy. You walk into the room and your friends start laughing. You feel happy. Would you be thinking I'm likable or I'm not likable? So it's kind of a concrete way to see, can they mediate those thoughts, feelings, and emotions. And when we look at the data, individuals with intellectual disabilities are fairly good at identifying the emotion that goes with an activating event. So you win the race, how do you feel? Happy or sad? 75% identify that pretty accurately. The ability to mediate other cognitions in this example, less so. Putting the situation and feeling together, choosing the correct belief, only 25%. And then if you have the situation and the belief, choosing the correct emotion, only 10%. So difficulties there. And most of the abilities are correlated with that receptive language ability. So I'll come back again and again to helping individuals with cognitive limitations using pictures, visual aids, things like that as one of the tools that we'll try to use. So to set the stage a little bit and moving a little bit away from strictly speaking about intellectual disabilities, assume that this was your referral that was coming through to you. Somebody who has a background of psychosis, voice hearing in the history, but they're described as a limited historian, don't describe much. and there's a question about psychosis or cognitive limitation. We don't have school or cognitive evaluations to kind of draw from, and we're wondering about cognitive limitation and or motivation for treatment. So how do we proceed? Now, again, if you can get access to good psychological testing or neuropsych testing, that's really the best way to get a sense of where folks are able, in terms of cognitively being able to function. But short of that, how do we work in the day to day? And I'm just going to give you a few examples, and I don't do this work all the time. So I'm sure there are others on this call who can speak to this in greater detail and more accuracy than I, but I'll throw a few ideas out there. So when thinking about like what adaptations we might make, first I'm going to kind of bring you to a model that I like by Lev Vygotsky, who's a Soviet psychologist, turn of the like 50s, 60s, did most of this work, but something referred to as the zone of proximal development. And the basic idea here is that we can all do certain things with our own ability, problem solving, thinking, all on our own. And then there's this space that he called the zone of proximal development. These are things I could do if I had support. If I had somebody to guide me, provide some structure, I could get there, but I need some guidance and support. And so that could be, in his mind, all learning presupposed a human element. And so there would be this more knowledgeable other that would be that person that would do it. But it could also be technology. So think about how many folks here have used YouTube to fix something at home, right? So you look it up, somebody's got a video and they show you how to do it. Zone of proximal development, right? I can't do it myself, or I'd really struggle. I watch somebody, there's some structured guidance. Hey, I can do it. And then there are things beyond my reach. So a lot of what I'm going to say is when you're working with individuals, be thinking about like what kind of scaffolding, what could I do that would enable the individual I'm working with to be able to, communicate their problems, needs, concerns, work in a way that helps them advance. And this is sometimes called scaffolding in the field. So it's strategically providing a certain amount of structure and assistance to help guide people to reach tasks that they wouldn't be able to do necessarily on their own, but with this guidance could help. So in the space of psychosis, particularly with cognitive challenges, using simple and concrete language when we talk about communicating, often starting assuming in a like open-ended question kind of way, but then depending upon the response, narrowing the questions, giving real life examples, maybe even, then giving options and fixed choices. So then just kind of seeing how well they respond to kind of structured choices like that. When there's attention and distractibility, keeping sessions shorter, using visual aids, taking breaks throughout, things like that, or things that you could potentially do. And these are general recommendations. CBT, for those who practice it or are familiar with it, has a particular structure. So there's a lot of attention to collaboration, setting agendas, working on focused tasks, doing homework, things like that. And so we've simplified the CBT structure for psychosis using this acronym called START. So we always socialize a little bit and check on how the person's doing when they come in. We set a target. We work on action items, which is two parts, active listening and then action planning. And this is always in collaboration. Then we take time to review to get a sense of what they learned in the session and also to get some feedback, and then focus on some take-home work. So in terms of cognitive challenges, one of the things that initial check-in, and instead of just saying, how you feeling today, or what's your stress level today, 0 to 10, I might use pictures and emotions with some rankings there, little check boxes or continuums, different things like that might be one way to kind of make that adaptation, to make it visual, make it a bit more active. If I'm looking for the target, and in particular, what the person wants to work on, and this is really important, CBT, it's less about symptom focus and more like, what do you want to do in your life? What would make your life more meaningful? How would what would make your life more enjoyable? Whatever it might be. So I might start with some of those open-ended questions like, what are you best at? What do you like to do? Things like that. And depending upon their verbal abilities, I might move to, in some fashion, using cards or pictures. We have this thing called a values card sort. So if they have trouble generating ideas, we could use that card sort. Or I could even ask them to kind of show me the kind of things that they would like to do. This is an example of our values card sort. So at the top, it has important to me, very important, not important. And there's a bunch of cards, and then you just pick the cards and put them into different categories. And so you don't have to generate it, it's there. And so it takes a little load off the working memory and attention. And then it's a little bit active and fun. So it takes the attention off of you a little bit. So it's a way to kind of work around that potential cognitive limitation, whether it's due to cognitive symptoms of schizophrenia or other things, folks tend to like this. Moving into the action phase, everything you try can be an active scaffolding approach. So if I'm going to teach a breathing exercise, I may start to teach it in a way that I might normally do. Like, let's practice slow breaths, taking a slow breath in and out. And I might use a very verbal approach. And then I might add some concrete components to it. Like, well, let's put our hand on our chest and one on our stomach and really breathe in and see if we can inflate our stomach. And then, and then exhale and let that decrease. Like, use something very physical to teach the breathing exercise. All the way up to one of my colleagues working with youth, when they want to teach breathing training, will talk about blowing bubbles. That if you use bubbles and if you do it in a certain way, which is actually good breathing, you can get more bubbles, right? So it's more of a diaphragmatic, slower breath. And so there's actually a reinforcement for it. So it has concrete components to it as well as making it interesting. So in each activity, you can start with a more verbally loaded expectation and then make it more visual, make it more concrete, depending upon what the person responds to. Another example of this could be one of the things we do in CBT is ask people to think about different ways to look at situations. And let's say the person is feeling like they're excluded from groups, but they don't want to talk about it. We might say, there's a person, see this picture in the center. How does he look? Maybe looks kind of sad. Why might he be sad? The one picture, well, the guy's walking away. I wonder what that's about, and then what are the thoughts that go with that? Nobody likes me. So you can kind of work on tasks indirectly. So take the focus off a little bit, make it very visual. And so then you get to some of the content, and you could also say, is there any other reason that person could be walking away? Maybe they don't like the person. Maybe they have somewhere to go, right? So then you kind of have something concrete and visual to help with it. What we talk about in CBT is alternative explanations, thinking to be flexible about explanations for things. Another strategy could be a role play, where there's a particular situation that happens, and you can shape the role play. So you may have an argument with a neighbor or something like that, and set up the role play to kind of walk through what actually happens, and then stop them throughout and identify what's the emotion, what's the thought that goes with that, what behavior did you do, and then you can kind of work with them around how might you change your thought in the situation in a more favorable way. So rather than thinking about, in this case, anger as a like, hey, I'm strong, it could also be associated with losing control. And so you could kind of talk about staying in control versus losing control as a way to motivate different approaches, maybe to be assertive. So just an example. CBT uses a lot of self-monitoring. So let's keep track of things, which may or may not be something that somebody is really looking forward to doing. So we try to make it appealing if we're going to help them keep track of things. So keep it simple, use colors. If their organization is an issue, try to have folders and binders that keep things together. And a big fan of personalizing for meaning. So one of the folks I worked with, we would have sessions. He was a huge Browns fan. So we developed a little activity schedule, had all kinds of Brown stuff at the top. So that would always kind of bring some of the interest, and we'd have his values. And then we structured the activity so that it was simple to fill out. He wanted to improve his sleep. So we just said, get to bed, get up by 9, get to bed by 11, just check it off, right? So not a lot of information to keep track of. The calm and fun activities, we just listed the main ones so he could just check them off on any given day, and then his work tasks. So to try to keep it as simple as possible with a little bit of visual appeal to kind of give it some appeal to keep doing. Going through the CBT structure at the end, we always ask, what was helpful today? What did you like the best today? And so this is a way to really get feedback and also to assess what stood out to you most, right? And this is a little bit of a cognition check. And I'm always surprised not always, but I'm frequently surprised that people will bring up things that I hadn't really thought about that they had focused on. And that gives me a clue to where their attention was in our conversation. So having a time at the end intentionally to review and then kind of develop some sort of homework with the person is always an important thing to do. Working particularly with folks with intellectual disabilities, but just in general, we always think it's a good idea to consider like who is involved, family members, caregivers, things like that. Families are complex, and they're interconnected systems with mutual influence. Particularly, the authors here are referring to individuals with intellectual disabilities who may be involved in different systems of care, and their difficulties arise between the clients' needs, families' needs, the other system needs, things like that. And stress is a common theme. And so reducing stress is usually one thing you can count on that you're probably going to spend time with. But we do know that when family are involved and they're equipped with knowledge and skills to be able to support their loved ones, that the outcomes are typically better, certainly with psychosis, with regard to hospitalizations, medication adherence, things like that. So where we can try to find out who the allies are and how to help the team, if you will, work together as effectively as possible. So just to kind of summarize, we want to keep the intervention simple, visual, active. Think about that active scaffolding, like what kind of adaptation can we make that could help in this situation for this individual, getting feedback along the way. Collaboration is key in that. And then just patient calm understanding, again, that the relationship is really the most important thing. And so, always spending time to develop that as part of this process. So that's all that I have. I'm interested in not only questions, but also other ideas folks have come up with.